My name's Ruth Bush. I'm a vascular surgeon. So who here does veins? Or do you just show up for the thoracoabdominals, the carotids, and the femdistals? So who here thinks they're going to do veins when they get out in practice? Everybody raises their hand. So it's about the last 2 weeks of training that the fellows or the residents come to myself or Dr. Coogan or Dr. Balthazar saying, teach us everything you know about veins. I'm going into practice and I know my referrals are going to be veins. You know, it takes a while to get some referrals that are arterial cases, but get some home runs, get some early wins, take care of the veins. They're going to pay for your practice. You think that femdistal is going to pay for your practice? Probably not, but they're going to be the fun, sexy cases. So that being said, let's talk a little bit about veins. I'm a little stiff, got some old person neck injury. I have no disclosures. So there's a lot of stuff to know about veins, and you're not going to learn it all in 20, 30 minutes this morning, and especially at the end of 2 intense days. But there's a lot you do need to know, and I would say a lot of what you know about arterial disease does translate into the venous world. You do need to know about the anatomy, the venous anatomy. Fortunately, it's easy. You all did go to medical school. You did take gross anatomy. You did look at veins. You may not remember it, but you did. So we'd recommend that you go back and review those and pay attention to some of your venous ultrasounds. You need to know how to evaluate the patients. You need to know what's called the CEAP or CEAP classification from the American Venous Forum. This is how we classify patients, and this is also how you're going to get them paid for and authorized by insurance companies, and we will talk about that. You need to know the indications on why you're doing a procedure. You know it for arterial disease, you need to know it for venous disease. A patient can't come to you and say, I just don't like the way this looks. Because how are you going to pay for that? How is the patient going to pay for that? When you give them a $2,000 or $3,000 bill, they're not going to be too happy. So you need to know what the symptoms are and what's appropriate indications. There's a lot of different techniques as well, and I'll go through some of those. You need to know what the outcomes are, and you need to be able to ask tough questions and let your patients know that you want to be realistic about what the outcomes are going to be. I told a patient once, I'm not going to give you back the legs you had when you were 25 years old. I want those. And she was just shocked. What do you mean? That's what I'm here for. You also don't want people to think that you're a cosmetic surgeon. And they're going to be, up on some cover of some magazine. And some people will think that that's what you're going to be able to do for them. So one thing to know is a lot of patients will come to you with just one leg. A lot of patients will come to you with both legs. There's no rhyme or reason to it. Sometimes people just have venous disease, superficial venous disease of one leg. The symptoms are going to be variable. Not everybody's going to have severe symptoms. People have different tolerances to pain. They have different tolerances to leg swelling, to leg heaviness. It also depends on what they have to do for a living. Are they working at H-E-B and they're on their feet all day stocking shelves? That person may have a different level of tolerance because they need to go earn a paycheck. You need to also look at some of the more global symptoms. They may not have varicose veins that stick out. They may be someone who comes to you just with, well, my legs are tired at the end of the day. A lot of these patients, remember, their primary care doctors are going to blow them off and say, you're just getting old, you're tired, you're on your feet all day. And they're going to come to you thinking, is there possibly something that's going to make them feel better? You get these people back to work, enjoying their life. Again, those are some early wins. And if you have some of those early wins with your primary care doctors, then they're going to say, oh, Dr. Balthazar, I'm going to send you my carotid disease because these patients are so happy, they love you. So, one referral may beget another referral. There's some of what I call the sort of get out of jail free cards with venous disease. That's someone who has had a thromboembolic event, hemorrhage from varicose veins, or has an ulcer, either active or healed. A lot of insurance companies, most insurance companies will not make you do any mandatory waiting or conservative therapy if the patient has one of those 3 events happening in relation to their venous disease. Multiple risk factors, you all know this from your study for V sites and AB sites, and just keep them in mind when you're taking care of patients. They get a copy of all these slides because I don't want to go through everything and read to them. It says more common. I did put there more common in women. I don't know if that's because more women present, or it's actually some of the studies from overseas especially have shown that women in screening studies may have more venous disease. However, who goes to screenings? Women. They may drag their husbands, but more women go to screenings. So on physical exam, you also need to be able to recognize different patterns of venous disease. Not everybody's going to have reflux at the saphenofemoral junction. And you also need to be in tune with your vascular tech. They don't just need to look for reflux at the saphenofemoral junction. It may be completely normal. They need to look down the leg. But in looking at the patterns of varicose veins, so you have somebody in front of you, you have them stand up, not lay down, because your offices are going to be cold. It may be, the 8 o'clock appointment. They lay down, their veins are going to collapse. They may not be very hydrated. So you have somebody stand up and you just look at their legs, let the veins fill, and ask the patient at the end of the day, what do you see on your legs? The patient's going to know they've had this for a while. So on physical exam, by looking at the pattern of venous disease, you can often predict what you're going to find on ultrasound and get a good idea and be able to communicate with your vascular tech, or if you do the ultrasound yourself, which I often do. So medial calf and thigh varicoses, think about axial reflux with the great saphenous vein. If you have varicoses extending over the lateral part of the thigh, there is a lateral venous plexus that might be on the more proximal thigh, but lower thigh, think about the anterior accessory vein. It's going to course over in front of, on top of the knee and then alongside the lateral calf. Varicoses on the outside of the calf, on the lateral aspect, think small saphenous vein. And then ones around the ankles, especially in association with an ulceration, think perforator veins. The C part of the SEEP classification is seen here. You all need to know this. I don't know why there is a C0. You have no disease. Of course it's C0. What are you going to report? But in any event, so C1 through C6, most physicians, most venous docs do not treat anyone under C3. Number one, it's cosmetic disease. You can go to one of these freestanding vein centers, which there's a lot of people that work there, but those are going to be your cash pay patients. So really it's someone who's symptomatic, which is going to be 3 or higher. Duplex ultrasound, you need to make sure that there's no evidence of DVT that would need to be treated first. Someone who has had a former DVT, you need to make sure that they've had some recanalization, that they have some type of outflow from their leg. Last thing you want to do is ablate their superficial system, their deep system's out, and then they have no venous outflow from their leg. I do look at the proximal vein function, saphenofemoral junction. I also make sure that I look segmentally down the remainder of the leg. Again, patterns of disease. The deep system's connected to the superficial system with perforators all the way down the leg. I think they renamed those. They used to be Hunter's, Dodds, et cetera. Now we just call them thigh perforators. Or calf perforators. You need to look at those and see if there's a different pattern of disease. For example, the patient I took care of Friday, I had ablated his saphenous vein from the thigh probably right at the knee level up to the groin in 2009. He came back with recurrent varicose veins across the medial calf and going across his shin. On ultrasound, he had a large perforator coming from his thigh, superficial femoral vein above the knee, crossing over and recanalizing the distal portion of his great saphenous vein. Top part was still ablated, great, but similar to when we have floods here in Houston, if one dam is there, the blood's going to find a way to get somewhere down those veins. Patients who have had venous disease and you've treated them are prone to having other episodes and recurrent disease. It's the gift that keeps giving. So on duplex ultrasound, you need to measure your reflux. Your tech or you is going to have to measure the reflux. What we're looking for to get approval from insurance companies is 500 milliseconds or half a second. This is just an example of doing a venous study. Again, I do a lot of my own. I work at the VA, and getting patients in to see my tech is literally an act of Congress. So I do it myself and with someone else doing compression just to document some of the cases. Some people in private practice do their own venous studies. I don't know, do you do your own? Yeah. Sometimes it is just easier. A lot of the insurance companies are going to want you to submit pictures or a report. That's not hard to do these days with the current machines. You just have to be careful when you're doing any type of ablation, and we'll talk about those, about different things that you may see in a vein. Most of us we've got decent endovascular skills, so, you know, I had to use 025 wire the other day to navigate up this recanalized vein. You know, it's fine. You all fix aneurysms. You do fenestrated endografts. These are tiny little catheters in veins. It is nothing compared to what you do in your arterial work. I talked about the indications. Really, symptomatic disease, chronic venous insufficiency, I believe is the ICD-10 term, and those are going to be some of the buzzwords that you're going to have to put in your insurance forms. And I'm happy to talk after this or some other time with folks. Most of us who do veins know what the different insurance companies require. We know what their buzzwords are. Your vein intake form may be divided into what, you know, is it Aetna, is it Humana, what is it, and what are their requirements, so that you make sure you check those boxes the first time so you don't have to go back and do it again. It wastes your time, and it also wastes your patience, and you need to get paid. We'll talk about current treatments. I talked about being realistic with your patients. If you Google venous centers, these are the pictures that you get on all of them, and this is what your patients, well, you got this woman in this little black dress, that's what I want to look like. You know, they don't put up these ugly pictures of yucco-looking legs with ulcerations to advertise their vein centers. People want to have an ideal to come look at. So things that you want to talk with about your patients, you want to make sure you know what the diagnosis is. You want to make sure that you're going to be treating the most proximal point of reflux. You're not just treating the visible veins, or they're just going to come back and the patients aren't going to be happy. And again, realistic goals, realistic goals. There are a lot of different modalities. I think you've heard some about the conservative therapies, and a lot of the insurance companies are going to want you to do a trial of what they call conservative therapy for anywhere from 6 weeks to 6 months, just depending on the carrier. They're going to want to know that the patient has exercised, that they're keeping their leg elevated. Sometimes this is impossible if they've got a job. They, you know, like I said, they're the HEB worker, they're a nurse, they're a doctor, they're a teacher. They have tried some type of compression stocking, and they want prescription grade compression. I have surgical stripping up here. I am not going to talk about that. I am going to talk about some of the different ablation techniques. There's thermal ablation, which you've probably all heard of, the radiofrequency or laser. There are what's called non-thermal, non-tumescent techniques, which is mechanical, chemical, or MOCA, and then chemical ablation with some type of sclerosant, and then non-thermal, non-tumescent, non-sclerosant, which is basically glue. So there's a lot of different choices, and you will have options. This picture is the only one I'm going to show of cervical stripping. That is one of our former fellows. That's Faraz Musa, who's the one whose face is cut off. He's also one of Dr. Lumsden's former fellows from Methodist, doing a vein stripping with his fellow, and that's what it took to pull that vein out. So we don't do that anymore. So I'm going to skip down to thermal ablation, the radiofrequency or laser. Anybody here done RF or laser? Not rocket science, right? Not rocket science. But you can make the patients very happy. I love doing veins because, number one, the patients are for the most part happy. Number two, they're not sick, because if they're sick and got a bunch of comorbidities, last thing they need is you treating their veins. They're not admitted to the hospital, so your partners are happy because they don't have to round on the patients on the weekend, and you don't have to come in.
Anesthesia loves you.
Anesthesia loves you. Lots of times, you don't even have an anesthesiologist there, and it gets paid very quickly without waiting for lots of complications to have gotten better. So radiofrequency ablation is one of the more common, or is probably about as common as laser therapy. I think there's good and bad things to both RF and laser. You pick one, you get good at it. The outcomes are the same for both. I've done both early radiofrequency and then the last version that's been out for about 8 or 10 years, Closure Fast. I've also done laser. You know, you gravitate towards what you know, and so there's no reason for me to go back and buy a laser generator. I already own a couple of RF generators, and the generators cost in the $20,000s of dollars. So again, pick one technique. Radiofrequency does segmental thermal ablation of the vein. You park the catheter where you want it to be, either in the small saphenous, great saphenous, anterior accessory, or some other branch, and then it heats up to 80-something centigrade for a certain period of time, and then you segmentally ablate the vein. It's very simple to do. Laser or EVLT comes in multiple different options for wavelengths. There's a lot of data available comparing one wavelength to another. It is a continual pullback method, so the tip of the catheter heats up, and then you pull it back continually at a certain speed to ablate the inside of the vein and denature that collagen. There are disadvantages. There's been studies. The one good thing about getting old is you get to publish your results. Is Christine here? Where's Christine? Back there. Henry Zahn was also a Texas A&M student. Christine's one of my former Texas A&M students who did a review with me for the World Journal of Surgery several years ago. So, there's good and bad things about doing any procedure. You have to realize that there's no free lunch in this world. There are disadvantages and there are complications that you need to let your patient know about. I'll talk about the hyperpigmentation in a minute. EHIT, or endovenous thermal injury, or basically a DVT following thermal ablation, is one of the major concerns. I always tell people there's a lot of things that can happen, bad things that can happen after a procedure. You need to know what's going to kill you, and that's what they're more interested in, and that would be a DVT or a pulmonary embolism. They didn't put my redone slides, but really what I want you to look at on this chart is just the first two lines looking at laser and radio frequency. Pretty much equivocal in terms of outcomes. They can close the vein, it can stay closed. One of the things that I want you to pay attention to when you're reading articles about endovenous ablation, whether it's thermal or non-thermal, is people will talk about the recanalization rates, but recanalization is not always associated with recurrence of symptoms. Patients can have their veins open up or have it segmentally recanalized, and they may be completely asymptomatic. So you don't need to you can't make an asymptomatic patient better. So not all those patients need to be treated. So you need to pay attention. Has it recanalized, and are they symptomatic? But they're pretty much equal in terms of outcomes. There's non-thermal, non-tumescent techniques. This is MOCA, mechanical chemical, and then chemical ablation, which is really foam sclerotherapy. What's good about the non-thermal, non-tumescent techniques? Anybody? It doesn't require capital, so you don't have to buy a generator. Those of you who are, what year are you all? First? Okay, so nobody's near the end of their fellowship? Okay, so when you're thinking about going out into practice, one of the things you got to think about is what kind of equipment do I need? Is it worth me having the hospital buying a generator, or do I need that ECOS machine to do the procedures that Dr. Coogan talked about? So you're going to have to think about some of these things. With the non-thermal, non-tumescent techniques or the glue, which I'll mention, you don't have a capital outlay. It's all disposable. And for those of you that have worked with hospitals and supply chains, they come out of different buckets of money. So the capital equipment comes out of one, disposable comes out of another. Okay, so let's talk about MOCA. This is the Clara vein. This is this little wire whisk that it's a catheter. The whole unit's disposable. It gets put inside the vein. You activate the whisk to cause immediate spasm of the proximal part. So say you put it up to the saphenofemoral junction. You press this little button, it whips around inside, it spasms the vein, and then you withdraw it as it's doing its little whisk thing to damage and denude the endothelium, and you're injecting sclerosant at the same time, so sotradecol or polydocanol to further sclerose the vein. So there's two different things going on. You're damaging the inside of the endothelium and injecting the sclerosant. Some people use this, they think it's fabulous. I used it twice, not so fabulous in my hands. There's been studies looking at it, comparing it to radio frequency. Again, good outcomes on both. Equivocal when you look at the patients and their long-term results. There is foam called Varithena, which is polydocanol. It's basically already comes pre-mixed in a can. Many of us agitate our own foam with air. Have any of you all seen that, where you hook two syringes into a stopcock and agitate them back and forth? to make your own foam. This already comes. It looks like hair mousse or shaving cream. It's the company says it's better. You've got consistent bubble sizes. It's used to basically sclerose. It's a sclerosant to do foam sclerotherapy. Again, it's just one can. You don't have to have any capital outlay. The cans are about $3,000 a piece, so they're prohibitive in my practice. The company says that you attach a syringe on the end and it fills up the syringe with, you press a button, fills up the syringe with the foam. So they say that you can get multiple syringes. You can use this in multiple patients. Problem with that in my practice, my hospital says you can use one thing for one person, similar to putting a syringe in a bottle of lidocaine. We've had to change so that we can't keep bottles of lidocaine on the back shelf, and even using a alcohol swab, we can't keep filling up syringes of lidocaine, one person. So that's a little prohibitive, but again, depending on what your structure is, you may be able to use this. Again, studies looking at how the foam does, I think in experienced hands, superficial or foam sclerotherapy is fine. There's what's called non-thermal, non-tumescent, non-sclerosant techniques, basically cyanoacrylate glue that you use to ablate an AVM or endo-leak. It has been approved for a long time for other treatments. Venous was approved in this country in 2015, and the reimbursement codes for just came out this past year to be able to use glue. Again, same methodology, getting a catheter up to the saphenofemoral junction, popliteal junction, whatever you're going to ablate, and injecting it, making sure that the proximal portion of that vein is collapsed so that you don't have any leakage into the deep venous system. The closed trial was one that showed that it was very effective. One of the nice things about the glue is that the company says you don't need compression afterwards. So with the thermal techniques, you want to compress the vein until that damaged vein has really sealed shut. This is like putting Gorilla Glue inside of the vein, so you don't need that post-op compression. You might need compression for the secondary varicosities so that patients don't get thrombophlebitis, but you don't need it for the vein that you just ablated. There are some special considerations when you do a superficial venous disease. Most of us will not take care of patients while they are pregnant until about 6 months after they delivered. Remember, the uterus is huge, sits on top of the pelvic veins. Women may develop lower extremity superficial venous disease that may resolve once their uterus shrinks back down and they lose that extra volume of pregnancy. So I would recommend waiting about 6 months following pregnancy. Acute DVT, again, you need some type of outflow from the leg. I would reassess the patients and see what has recanalized. And Dr. Coogan talked about patients who may have had recurrent DVTs, chronic DVT, need to think about some other type of higher disease. Question comes up about anticoagulation. I don't stop any anticoagulation for endovenous ablation. I tell the patients they may have a little bit more bruising. They may have a little bit higher recanalization rate. Depending on why they're on anticoagulation, it may not be worth the risk to stop it. Again, I have to point out one of my other students, Avi Bunnell, is a third-year vascular resident at Medical University of South Carolina right now. Superficial thrombophlebitis, something you have to consider. Patients, once you ablate a superficial vein, those secondary branches, if you don't take them out at the same time, could clot off and cause the patient pain. So if you're going to do stage procedures, do your ablation and then your phlebectomies later, you need to think about superficial thrombophlebitis and really encourage your patients to wear their compression. So again, there's multiple different techniques. There's this thermal, the non-thermal, non-tumescent, and glue that you can also use. I think you need to have a combination of techniques in your armamentarium. You don't need to have them all. Most of them are safe. They're safe in experienced hands, and if you're doing them for the right indications. Post-treatment, most of us wrap our patients afterwards or have them wear their stockings, again, to prevent thrombophlebitis. I tell the patients they're not going to have immediate results. Some of the patients who have heaviness or swelling, they may actually get better almost immediately, but it may take a while for some of the secondary varicosities to go away. We talked about compression. It can be very hard, especially for older patients, to even get on the compression. Dr. Coogan mentioned the Ferro wraps, the ones with the Velcro, maybe a little bit easier. I still do post-op imaging after my endovenous ablations. You do too? Yeah. Some people do not do post-op imaging. They just only do it if the patient's leg swells. I still look at their saphenofemoral junction or saphenopopliteal junction to make sure that there's no thrombus extension. That's what you want to see. You want to see that the vein is completely ablated up to the junction but not extending into the junction. There are multiple different things you can put in your tumescence if you're doing a thermal ablation. I add steroids to mine. It seems to prolong the anesthetic or analgesic effect of the lidocaine. It also may help with some hemosiderin deposition following that. I mentioned endovenous heat-induced thrombosis. This is one of the more concerning things. It's why I do post-op ultrasounds. And just to let you know, I don't do complete full ultrasounds. If patients are sore, they don't want you touching their legs. I've actually trained my nurse practitioner just to look at the saphenofemoral junction. She knows to look for Mickey Mouse. If it's not completely compressible, she'll call myself or the tech to do a more thorough ultrasound. I mentioned there's no free lunch. There's different complications that can occur. You need to know about them. You need to tell your patients about them. We mentioned the endovenous heat-induced thrombosis. Patients can get varying degrees of bruising, somewhat hard to predict. This patient down here was a younger physical therapy professor at Texas A&M. The hemosiderin deposition that may leak and cause these stripes on their legs can be very worrisome and very unfortunate for patients. It may not come out till 3 to 4 months after you ablate their legs. Unfortunately, by the time this came out, I'd already done her other leg. I did them a month apart, so she ended up with stripes on both her legs. Not happy. I mentioned the complications. You'll have these on your slides. And what I do follow up. You know, most of us put that we want to follow the patients periodically. What's going to happen when the patients are better? They're not going to come back. And that only makes sense. You fix their problem. They'll come back when they have a recurrent disease. I had actually eliminated the phlebectomies from my talk, but it didn't make it here, so I'll move on. One thing I'm going to tell you is that us people with law degrees hate the term learning curve. We consider that you're making your patients your guinea pigs. So I would encourage you not to say or tell people I'm still in my learning curve for different things. So again, the outcomes reality, they all are going to work. All these ablation techniques are going to work. Patients are going to have good closure rates. They're going to have low recanalization rates. Just make sure you're doing the right procedure for the right indication and get adept at one or two of these techniques. So lots of choices. I would encourage you all to look at the American Venous Forum. Dr. Coogan mentioned it several times. This is the largest national and really now international organization that is solely devoted to venous disease. And it's only about venous disease, and I encourage you to read Journal of Vascular Surgery, Venous and Lymphatic Journal as well.